Good afternoon, everyone. I think I can see we've got about 52 and the little tally going up as people are coming in from the waiting room. So welcome to this afternoon session as part of the autumn lecture series from the NHS Confederation. I'm Helen Thomas. I'm the Chief Executive of Digital Health and Care Wales, and I'm the chair of the panel today. And I'm joined by my illustrious colleagues, and I'll introduce them in a few moments' time. So yeah, welcome to the session. It's excitingly titled Devices to Data, How Digital is Transforming Patient Care. And we're going to do a bit of reflections really on some of the digital successes that we've seen in response to the COVID pandemic, but also a bit of emergent thinking, a bit of forward looking on what this means for us really. So the objectives of the session today are to highlight how data and digital are revolutionising patient care, explore digital platforms and how they have the opportunity to empower patients and inform clinicians, raise awareness of the importance of patient data and how it's already being used in NHS Wales, to set out some of the emerging thinking and future aims, and to explore the importance of collaboration across industry, the NHS, and of course with citizens themselves to enable that digital innovation. So we're going to have some great examples actually, because we've got a diverse panel with us today, and really to see and to hopefully bring to life kind of the opportunities and the benefits, if you like, for the use of data and digital in health and care. And I think actually if this last 18 months has perhaps opened our eyes to those possibilities, to see how data and digital actually are going to help us to transform and even to sustain and improve. And if we're honest, some of the opportunities that we've embraced over the last 18 months, they weren't that novel, actually, unlike the virus itself, they weren't that new. We kind of just needed that push, didn't we, to kind of make the change. And, that's often the case with transformational change. Actually, you need a bit of a burning platform, and of course, COVID presented that kind of backdrop for us, things like to shift to remote working, to have that kind of near real-time information on our, the current situation, the current pressures, and even to complex data trawls and linkage processes to try and identify our most vulnerable in terms of being able to offer more support and protection against the virus. So kind of and I would say this as a data professional, as an information professional, data did become kind of a bit of the star of the 5 o'clock catch-ups from Downing Street and all of the next slide, please. But who'd have thought we'd have been glued to those, to the screens and actually really understanding and watching all of the data to inform all of the decisions that we needed to make and the directions of travel that we took. So I've been kind of personally reflecting on really what were the key elements really? How did we kind of achieve so much digital and data change? And I guess the first thing, as I reflected, is the necessity. We had to get on with it. We had to do something different in order to keep connected and keep communicating. We also had shared objectives. There was a common goal that we were, all doing our bit, if you like, in terms of what our role was in the response. I think we also increased our tolerance for change. We kind of just got on with it, and because we had to. There was no choice in the matter. If we wanted to stay connected, we had to work in a very different way. And I think I'd also reflect that we saw a really strong Team Wales approach to the response here in NHS Wales and wider than NHS Wales, in Wales itself, across multiple public sector organisations and agencies, academia and commercial partners as well, in terms of being in this side by side. So it was a real can-do approach, I think, in terms of what kind of marked, I think, the last 18 months and why we've been able to really kind of embrace the opportunities and the possibilities of digital. So what does this mean going forward, really? So I've heard the phrase from a number of people, we don't want to snap back to the way that things were before. And I think so we've got to really kind of ensure that we support organisations and staff on the ground and our patients and citizens out there to actually stick with the changes that we've seen and really see how we can have a more blended approach that is using digital interactions and digital technologies to offer something different, actually, in the way that we're delivering health and care services. So lots of opportunities, I think, going forward. Different approaches, maybe digital first in some aspects. But I've got three senior leaders with me on the panel today who are going to take us through some of their own reflections and share some of their emergent thinking and where we're going next with some of this. So I'm going to ask the panel to introduce themselves and then we'll kick off. So Faith, if I can ask you to introduce yourself first.
Absolutely, thanks, Helen. Absolutely delighted to be here. I'm Faith Grange. I'm the Director for Local and Regional Government for Microsoft in the UK.
Thank you, Faith. Chris.
Yes, thank you, Helen. Likewise, it's a pleasure to be here. I'm Chris Davies. I'm the Chief Exec and Principal of the Institute of Clinical Science and Technology, often referred to as ICST.
Thank you, Chris. And Rebecca.
Hi, my name is Rebecca Cook. I'm the Programme Director for the National Data Resource Programme and part of Digital Health and Care Wales.
Thank you, Rebecca. And before I kick us off, then just to remind everyone, we've got the chat app. So if you've got any questions for the panel, we've got about 20 minutes or so at the end of the session where we'll have a Q&A. So if you would post your questions in the chat and we'll pick them up at the end then as part of the Q&A. But Faith, then if I can ask you to begin the session for us, please.
Absolutely, dear. Delighted to. Thank you, Helen. So yeah, as I said, I'm the Director for Local and Regional Government for Microsoft in the UK. So I have a team of people working with regional devolved government across the UK, and that includes the work that we do with NHS in Wales. So it's really interesting to me that the title for this event is devices to digital and to data, and that could pretty much sum up what Microsoft does, actually. You know, from our range of Surface devices through our modern workplace and Teams platforms and business application technologies to our Azure data platform, we really work on deploying our solutions to meet our overall mission, which is to empower every person and every organization on the planet to do more. So what does that mean in a healthcare context then? So if we get up the next slide, Claudia, please. Oh, I do feel like I'm on one of those briefings now, directing the next slide. If we start with this, I mean, hopefully this will be to many of you recognizable in terms of how we're looking at healthcare transitioning from what is quite a reactive process with kind of a lack of connectivity in some places, really through to a much more collaborative approach, enabling preventative care. And that is what citizens are expecting. In a lot of ways, there's no surprise that we've ended up with things, you know, the NHS has grown so exponentially in terms of the size of population and the types of services it has to deliver from when it was kind of first conceived. But really, this is about how can we change? You know, how can we have a focus on wellness and well-being rather than just treating the ill? How can we have personalized data and treatments, an ability for healthcare professionals to connect from anywhere on multiple devices and to be able to view data and for it to be secure? You know, from a clinician's view, that access to the latest fluid data that is so important in kind of the changing response to an individual's kind of changing healthcare. And then for the executives, who are massively important in the healthcare environment, actually the ability to make information-based decisions through being able to interrogate data that's been brought together, to use the latest technology and not have kind of the large expense of continually starting with data collection and plugins every time that you want to introduce a new piece of technology. And we absolutely see this as Microsoft. We're really bought into this, and we partner very closely with healthcare professionals to develop our solutions in this space. Next slide, please. And we also have to remember that in this world now, there is a post-COVID context for the UK in terms of health and life sciences. So, you know, the realities, as Helen alluded to in the introduction, of the pandemic, it's really transformed every business and profession, but, you know, none more so than in health. And actually, while there have been a huge amount of challenges that have come out of that, there are some real opportunities too. And as Helen also suggested, there's quite a lot that went on, that it wasn't that we weren't capable of doing it, it just accelerated it. And so how do we make sure that in that acceleration, we keep the good things and also focus on the things that we've now got to resolve? I mean, you know, the recovering elective care, you know, there's nearly 5 million on the total waiting list, you know, across the UK, more than 400,000 waiting over 1 year, which was less than 1,000 pre-COVID. And 20 million fewer outpatients appointment, you know, in the last year. It's going to take 3 to 4 years to recover if we continue to do things in exactly the same way. So what role does digital have in helping to take some of the burden off, to be able to kind of accelerate through that? There will be an ongoing COVID demand without doubt. I know we'd all love to think that because things are starting to open up, the pandemic's gone away, but it hasn't. COVID is something we will have to continue to live with. So there's the potential for further waves, variants, and we need to continue with that kind of test and trace to be able to do that. But actually, one of the great kind of success stories has been some of the home testing. I mean, you know, millions of PCR and lateral flow tests have been carried out from homes across the country over the last few months. And that would have been unthinkable, you know, in previous times, to have ever been able to have that kind of mass testing done by individuals in their own homes. But actually, even the distribution channels, you know, mail, local pharmacy, employers, there's a real opportunity here to think, well, what other conditions might benefit from that kind of at-home testing and screening? There's been remote patient monitoring, the opportunity for virtual wards model to mean that kind of subacute patients could be managed in virtual wards to relieve pressure on hospitals and improve the patient experience. And then GP virtual care, you know, so many GP appointments have been done, you know, through video and through telephone. And actually, there's a significant number of GPs and in fact patients that would like to see that kind of care remain rather than always having to be a physical appointment. We're absolutely not saying that physical appointments don't have a place, of course they do, but this is how do we really start to enhance those things with digital. We've got new research models, and again, I mean, the UK's led the way on this in terms of COVID. And we're looking at how can digital assist in terms of diagnostics. So, you know, there's over 300,000 waiting 6 weeks or more from referral to one of the 15 key diagnostic tests. You know, and there's particular issues with some of those through social distancing. But again, what about, you know, there's a wider opportunity with diagnostics in terms of what of those tests that could be done that could be enhanced by digital. And we've got probably some of the kind of more future type based things like, you know, the genomics. Genomics, again, UK is world leading in terms of sequencing the COVID genome, working out kind of the new variants. And what does that say for how we can use genomics and the ongoing sequencing and actually to be able to deal with other conditions that have a very, very individual impact, like cancers, for example. And then, you know, adoption of AI, we've got some great, really exciting things. And of course, you always have to think ethically around the adoption of AI. But the opportunity when you have data to run machine learning and start to get predictive, using the right kind of models is one that can't be ignored. And then, of course, you know, there is the ongoing pressure of morale, staffing shortages. You know, how can we support that? How can we do things differently to support a workforce that has been under even more undue pressure than they've ever been before? Next slide, please. So I think, as we can see, it's really highlighted the crucial role that digital transformation's got to play in this space. And here's just one example of where I think it's been phenomenally successful between ourselves and the work that NHS Wales have done, where we work very closely to do the test, trace and protect. Helen again just pointed out brilliantly at the start the importance of working across organisation, not just across public sector organisations, but using the market, using the technology companies that are out there who really want to lean in and help. And I hope that that those of our customers on the call feel that we did lean in and support around that. But these have made a huge difference, using Teams to be able to stay connected, to be able to work in a different way, the test and trace out, the fact that people could log themselves online on an application, that, all of that, was significant. It was there, but it was significantly accelerated. And so the opportunity for us to put that into other contexts is massively, massively important. Next slide, please. So we've got a bit of a mission in terms of how we want to work with the UK health and life sciences sector. And you've got it there. And this is really about being able to enable better health, better care, better experience and lower costs for the NHS and for its clients, which is ultimately the population of the UK. Next slide, please, Claudia. So we've got some priorities for the year ahead, unsurprisingly, supporting the post-COVID recovery. We're looking at, for example, with NHS England, we're actually looking at an AI-enabled decision support to manage and reduce the backlog of elective procedures. Again, using digital where it's appropriate within a process to enable the prioritization and support and allow the clinicians to really get on with that frontline service. Helping the NHS to reform and modernize, this is actually about kind of bringing together the social care element, which lots of my customers in the local government space have to work on, and the kind of acute NHS care systems. How do we bring those together and integrate them so that actually we look at well-being across the population? And that requires up-leveling of infrastructure. It requires integrated collaboration, increased sharing of data in a secure environment. And then we're also looking at how do we strengthen the UK's life sciences ecosystem, so supporting clinical trials, research environments and genomics. And then supporting the sharing of standards to really embrace innovation. So, our Azure data platform offers extensive polyglot support for languages such as Go, Ruby, Python. I mean, there's all of these different kind of data, kind of coding languages. Our developers can write software in the language of their choice, but that really brings together the opportunity for kind of those kind of standards and allows open source services that we really want to support as part of Azure. And the Azure API for Fire allows you to create and deploy a Fire service in just minutes to leverage the cloud. And that means that we are really trying to develop this out to be designed for rapid performance to really kind of size the data sets that are being managed. And that's enormously important as we try and bring together data, because there's nowhere probably that has as much data as the health system in the country, that we really have to make sure that it is open and shareable and easy to access for us and our partners. Next slide, please. This one builds out, but this is really talking about, we've launched a Microsoft Health Cloud, which is an offering for our kind of health customers with citizens in mind. And it's designed to support partners with third-party offerings with open and defined standards. And this is really where the data starts to make a huge difference, to be able to deliver against all of these primary requirements that you see on the outside there, the personalized care, the collaboration for the care team. And all the while it is about keeping health data secure, compliant and respecting privacy, which we know is one of the key concerns when we start to talk about sharing patient data. Next slide, please. I've got a couple of kind of almost emerging kind of technology sort of examples here for you. We've talked about migrating to the cloud, and we're working with brand new partners, entrants to our market, but probably no stranger to some of the technologists who work specifically in healthcare, starting to migrate their services to the cloud, looking at the opportunity to use HoloLenses within virtual care. And again, we've got some examples where, that can really has the capacity to kind of accelerate and augment treatment, saving time and money, as well as that really can help to support the training of clinicians in a very practical way, and start to accelerate that as we look to get more clinicians actually into the workforce. And then the opportunities that AI actually has for kind of supporting health. There's just an example here with a project called Inner Eye, where we're working closely with Addenbrooke's Hospital in Cambridge. And this is where, when we talk about cancer treatments, there are three main ways of treating patients. So there's surgery, chemotherapy, and radiotherapy. With radiotherapy, it's critical you kill as much of the cancer as possible and as little of the healthy tissue. So what Inner Eye actually allows oncologists to do is to achieve 3D contouring of patient scans in minutes rather than the hours it traditionally takes. So that then enables them to develop the execution plan for radiotherapy in a really, really highly targeted way. And the assistive AI technology gives experts full control of the output accuracy, but allows them to enjoy really high levels of consistency and potential cost savings. So that's now technology that's starting to be rolled out across some elements of the NHS. And we want to use that to kind of as part of democratizing medical imaging standards, to make it available. And we've got a platform called GitHub, which has kind of open standards, and anyone can go on there and take those standards and be able to develop those out to potentially for other imaging type projects. I'm going to rush through these last couple of bits. Sorry, Claudia, next slide, because I really actually want to show you the slide at the end. So we have a huge number of partners. We are about creating an open platform that our partners can work with us on to deliver really, really strong kind of use cases and applications for the technology. Next slide, please, Claudia. And this is really where I wanted to get to, because ultimately, this is all about improving lives, making things better, and thinking about it from the patient point of view. And I just want to leave you with this short video just to illustrate that when we come together, when we get the data right, when we use digital in the right way, just the kind of difference that it can make to the patients and their families. So please run the video, Claudia.
I think in the back of each of our minds, we were planning a little funeral, and just didn't know where it would go after he was born.
We'd hear a song on the radio, and we'd be like, maybe that's one we'd like at his funeral.
Winston was diagnosed with HLHS, which is hypoplastic left heart syndrome.
1 in 100 to about 125 babies are born with heart disease every year. And out of those, about 1% are born with half a heart. Out of all the heart surgery we do, this is the most high risk.
They lose about 25% of these babies in between the two surgeries.
The standard of care at the time was to send these families home with a weighing scale and a pulse oximeter and a 3-ring binder, and they were asked to record measurements of their baby every day.
So we needed a method that we could actually send something home with the parents so that we could better monitor and be alerted if there were conditions that we were concerned about with the patient. We have a Microsoft Surface that we load our software on. We call it CHAMP. We decided we wanted to use a modern app with Windows 10 as the operating system.
We would log all of his vitals, and that app became this seamless piece to his care.
With the daily reports that come in from the Azure cloud, if anything is an outlier that needs to be notified to us immediately, it'll alert us.
One night, we're debating, do we call, do we not call? But we logged it in.
When we were looking at his information, he had a couple days of not gaining weight. He was breathing a little bit harder, and he just wasn't happy on his video.
They could pull it from when he was doing fine and saying, okay, a couple weeks ago, this is what he looked like. Now he looks like this. We think it is part of his aorta.
We were scared. It was real fast.
They did the procedure the next day, and then I think he went home the day after.
This technology literally saved his life.
The first time that I heard a child's life had been saved with CHAMP, I left the room because I kind of needed to tear up in private because it was a dream that I'd had for a long time.
The goal is to get this out to as many patients as possible so that we can help save kids' lives throughout the world eventually.
For everyone behind the scenes, we're very thankful for it. Saved his life, and how do you say thank you for that?
Thanks. Back to you, Helen.
Thank you, Faith. I think a little upstaged there by Winston, actually, at the end. Yeah, lovely star performance. But yeah, thank you, Faith. And we'll come back to some questions from some of the stuff there at the end. If I hand over now to Professor Chris Davies, then to take us through his slides.
Thank you, Helen. I'm just going to load these up. Can you see those?
Yes.
Right. As I mentioned before, I'm the principal and CEO at ICST, and we've been working for some time now implementing digital solutions with NHS Wales, and these are very much at scale. So some of you will have heard of us. We've been working here now with NHS Wales for some years, but for those of you who haven't, I'm just going to give a bit of a resume of what we've been up to pre and post COVID. And actually we were delivering various digital programs in the respiratory space for a while before COVID, which meant that we were well positioned to help when COVID came along. And those conditions or programs were very much around asthma and COPD and long-term management of those conditions, from very much large-scale programs for patients with patient apps and healthcare professionals with quality improvement programs and national guidelines. So when COVID came along, and there was a problem with how to disseminate and support various hospitals around the country, the 19 hospitals that were treating COVID, we worked with various clinical leaders within NHS Wales to deliver a COVID hospital guideline to disseminate the latest evidence that could be trusted, that was dynamic, that might need to change, sometimes change very rapidly, to make sure that anybody who needed to get that information and understanding could do so anytime, and updates were pushed through the system so that people were informed of it. And leading on from that, we then audited the first and second waves, and currently auditing the third wave of the outcomes of the hospital guideline. And there's been some very interesting data coming out that has helped inform practice, certainly from the first to the second wave. And moving on from that, the same principles within primary care guidelines during COVID, and then right the way through to supporting in a similar kind of way the healthcare population around COVID recovery for patients with long COVID, because again, it's a new disease or sequelae of COVID, which is poorly understood. So how is it that you get that information quickly and timely? That also takes us through to a COVID recovery app, which is there to support patients with long COVID, and that's been launched now for about 9 months. We also work with the liver group, LDIG, looking at liver blood tests, which are quite commonly abnormal, but maybe markers of liver fibrosis, and when picked up early, can make a huge difference to the impact of people ending up with liver failure. And we're also about to embarking on some sustainability agenda, particularly around greenhouse emissions with inhalers, which actually contribute about 3% of the greenhouse, the carbon footprint for NHS Wales. So that's some of the stuff that we've been doing. If you haven't heard of us before within NHS Wales. But what I'm going to do now is talk just for a little while about some of the principles around data, and particularly at scale, and largely focused around the interaction for healthcare professionals and patients. I'm going to bring up a little bit of one of the pitfalls, and then I'll go into a little bit more detail about some of the programs, so you can see what we've been up to as well. So I think the first thing that I'd like to discuss is the concept of the significance of what has happened in what I see as a very, very important and interesting, quite a privileged time by luck. And that is where we are in the world today. So information previously was transferred through the spoken word, and a revolution came around a couple of thousand years ago when paper came into being, and that really changed things. People at the time may not have known how much that was going to change the world, and it's changed the world to today. And now we're going into the digital world. And if we just go through these, because I think this is hugely significant at this time. So the spoken word was very slow, both in terms of disseminating in geography, but also being passed down over time. And there was loss of fidelity as the spoken word was, and that information was passed through. Fidelity was lost. And paper really changed that. It made things faster, slower than digital, but certainly faster than the spoken word. And it created the ability to keep fidelity and also then to scale. Now, in the last couple of decades, we enter into a world where we have the ability to transfer information and data in a very, very fast way, which can be responsive, which enables fidelity to be kept and scale. But I think that the big thing here, which is going to be with us now for generations, centuries, whatever, who only knows. But that is the way that the way that digital allows information and data to pass in a two-way system. And that means that not only does information go out, but also information can come back. And that relationship is something which is a complete change that has not happened previously. And we're at the beginning of this era, and it's very exciting because it completely changes the way that we do things and the possibilities of how we can use that if we use it to empower the system. So the point here really to consider is, first of all, that the digital infrastructure is very much the messenger, not the message. And just as with paper, one grew up, we've all heard the phrase, it's not worth the paper it's written on. Well, the digital world is only as valuable as the message that it delivers. And so there are a lot of digital technologies, and that gives us an immense power as a messenger, but not necessarily as the message. So those two things are very important to differentiate. Digital is normal nowadays, and although it's relatively new, there are many sectors of the population where it's not innovation. It is their normal life. There are many people under the age of 30, certainly, who have never bought a newspaper, who acquire information and data in very small bite-sized pieces throughout the day, and the way that they interact with the world is very digital, and that's their norm. It is not the new norm; it is the norm, and the expectation of the digital world within that population, which is growing all the time, is incredibly high. So the bar is high. And I think that's sometimes very important to, when we fight for a presence in the system, that if the quality is not high, then we will fail to do that. So understanding our relationship and our ability to harness the digital is, and the digital infrastructure and world is very important, so that we understand the limitations, particularly in healthcare, of what we do and don't have. And I would say that one thing that is important is to learn from other industries who are further along that curve. There are many industries over the decades who have spent, as industries, billions of dollars perfecting, certainly fine-tuning the empowerment of the digital world, whether it be media, whether it would be the banking system, whether it would be you name it. We know as it's all around us, and there's a lot to learn from other sectors that are directly transferable into healthcare. But a little bit of caution about data, which I think is one of the big issues that's often, for me, which I think is very important, which often is not spoken about, and that is so data. We view data like food at the Institute. It's fundamental to function, but too much of it, and poor quality and poor provenance, is not good for you, and we call this data diabetes. Too much poor quality data does harm. And the world is congested now with so much information that deciphering that which is true, that has got a good source, or just the fact that there's so much of it, is actually becoming more of a problem than a solution in many contexts. And I think it's a very important fundamental that sometimes just doing the things that really matter, and of the right quality, is very powerful, and less is more. So at ICST, population innovation is what we are about, and implementing that. And in order to do that and to create scale and pace, in my view, to create things at scale and pace, it's the pace that is the fundamental. Creating things at scale without pace is almost impossible. And we all hear about things when they go viral. It's the pace of the viral nature that creates that scale, and digital enables that. So that's one of the real values of this. Simple standardization, everybody knowing, learning, and doing the things that really matter changes population behavior, and that's a large area of where we focus as an organization and as an ethos. And to do that, one needs a systematic approach, or a system approach, and I'll talk a little bit more about that in a second. But this slide seeks to demonstrate one of the things that's a bit of a difficulty within many systems, like the NHS not being immune to that as a large organisation. And that is, if you take the dots up here, these represent pockets of excellence. And they exist all over the NHS. And for all the right reasons. They drive standards, they often do research, and centres of excellence are core to progression. And if we take this line here as a standard, one could call that a minimum standard that one would aspire to. The pockets of excellence are important, but in changing population outcomes, it's often the population to get through that standard, to reduce variation, which changes population outcome as a whole. And we focus on this population being nudged through the system to try and achieve a progression of standard across a whole population, rather than creating more pockets of excellence around the country, which is something that is already done incredibly well. So that in order to have a system that works with that, it's really about taking policy to patient and joining that system up. It's about empowering all the layers in order to do that. And so this is something that philosophically we come at this from a population level stance point rather than a pilot level stance. With pilot levels, they work very well, but they're usually in controlled environments. And the difficulty with a pilot study or exemplar is actually scaling that up. It's much more difficult to scale it when you suddenly have to relinquish all the control that you have in order for that to be taken on, or even to get and to incentivize other people to adopt that elsewhere. Our approach is about the population, so that's the starting point, and then best practice coming into that. And so that's what that's what puts us into the system. And in order to do that, an implementation strategy is the thing that's fundamental. And at ICST, we use implementation science methodology to underpin the way that we would implement a program on a national basis. So this is, for example, just a simple diagrammatic feature of an NHS structure. And the issue here is that if one doesn't create a value proposition right the way through the system from policy to patient, and look at having adoption, alignment, etc., right the way through, then one is less likely for digital innovations to succeed. And that means there's quite sometimes a plethora of things that need to exist within the system, all underpinned by those simple things of everyone knowing, doing and learning the things that really matter. So patient-facing apps, but guidelines, education and quality improvement projects that underpin that for healthcare professionals as well as patients. These slides go through just to see some of the things that we do and how we present those things. So we have guidelines with videos, with tutorials, with TV shows that are simple to use at the point of care, designed to be used by practitioners either as resources outside of the consultation room or within the consultation room, which are dynamic, that can be updated digitally at any point in time, but also then that offer feedback of from healthcare professionals or obviously patients if they're aimed at patients. And with that support with learning and a whole education package to support that. Events similar to this, more of those have become digital, of course, for obvious reasons, but not exclusively. One of the things that's within the digital world that makes it much easier to facilitate. We have a phrase that we say, if you want someone to understand 3 things that make a difference, don't tell them 10 things. And often with leaders in clinical leaders, we would ask them, if you could get people to do 3 things, but across the whole nation, how would that empower you? And the answer is, well, if people did just these 3 simple things, but everybody did them, it would change healthcare. And one of the things that digital has enabled us to do is to actually interact in a way where you can only tell people 3 things or ask people 3 things or present 3 things. Whereas in the physical sense, for someone to actually go to an event for 10 minutes, it might take them half a day. Nowadays, people can go to an event for 10 minutes and it costs them 10 minutes. and they can do it when they want to do it. They can do it at 10 o'clock at night, they can do it at 8 o'clock in the morning. And that makes things incredibly efficient. That's very, very much part of the whole empowerment of the system. Then there's quality improvement, supporting healthcare professionals to implement those things into action where necessary, and to patient-facing apps and the empowerment of the patient, creating either a surrogate of the expert patient or to create the expert patient over time. The patient apps are free at the point of care. They're available on the app stores. They're designed with leading healthcare professionals within Wales, bilingual, and the feedback that comes back in from the apps from patient usage, that data goes back into the system. It goes into the hands of clinical leaders to enable the clinical leaders to support with more education and services, or the data that comes back to help understand what is happening where and with which demographics around the population, and to improve service provision as time goes on. So in terms of looking at what comes back, and one of the things that, coming back to that first slide, or the second slide, talking about this two-way relationship, and not only can we pass information and data out to healthcare professionals, patients, or whatever the target audience, it's also possible to see what comes back. And so we monitor and we know where people are using the patient devices or healthcare professional platforms. We know that there's as much uptake in North Wales to Mid Wales to South Wales, and from east to west. We know that, for example, there's 500,000 minutes of videos that have been watched. We know that there's 900 COVID-ready assessments that have been done.
Sorry to interrupt. I'm conscious that we're probably fast going to run out of time. So do you want to finish with some of your key messages? So I'll go through
quickly. And more data coming in then from COVID recovery app. So in summary, digital gives scale and pace, and most importantly, a two-way relationship with the target population. Beware of the quality and the amount of data. Simple standardization creates population change, and learn from other industries that have invested in time working a lot of things out that we can learn from. Thank you.
Thank you, Chris. Sorry to push you there at the end. I'll hand over now to our final panelist, Rebecca Cook, who's the NDR Programme Director at Digital Health and Care Wales.
Thanks, Helen. Okay, thanks everybody. My name is Rebecca Cook, as I have already introduced myself. I'm the Programme Director for the National Data Resource, but back in the beginning of 2020, I led the delivery of the data workstream supporting the COVID-19 pandemic. So I'm going to go through today and give you some of the insights behind the data. Behind our Welsh pandemic response, some reflections on some of the challenges associated with our data response and the future opportunities that come with the National Data Resource Programme. So Digital Health and Care Wales, for anybody who doesn't know, is the national IM&T organisation for NHS Wales. And in there, we have a Central Information Services Directorate that has responsibility for collecting, storing, and analysing all of the mandated data flows across NHS Wales for costing and performance management, official statistics, and service improvement. Our central data warehouse holds over 30 years of healthcare data sets, and those data flows range in frequency, size, volume, and structure. Around about February, March last year, as the Central Information Department, we recognised quite early on that we would need to provide a whole range of data and intelligence to multiple organisations to monitor the outbreak of the disease and the impact on services. So we knew that we had a lot of data out there in local data warehouses and with our healthcare providers, but we would need to have an all Wales view of that data, which made us really sort of pivotal to the data response. So we set out quite early on determining what data we already had in our data warehouse and what data gaps we had and what data we would need to get hold of. So we had a whole range of new data feeds that we had to bring into the centre. We were able to do that under sort of special allowances and sort of regulations for accessing data under the pandemic. We created a COVID data store within the national architecture. We created a whole range of views that we needed to pass on to Public Health Wales for infection surveillance, Welsh Government monitoring, and also up into the UK government as well. So we had a whole range of new data pipelines coming into the centre, from our lab data, from WAS data, primary care data, GP out of hours. But actually, we also needed a lot of data that didn't exist in the system. So we had to create new means by which we could collect data and get it in quite quickly. And they were some good old fashioned Excel spreadsheets that captured some data into the centre around capacity and occupancy data. You know, how many beds did we have available? How many spaces did we have in the mortuaries? And then later on, we got into more workforce data and oxygen levels, etc. So we had a whole range of different data coming into the centre, which was sort of system derived data as well as manual data collections. We created a COVID data hub, and this was a business intelligence dashboard really that tried to provide as many visualizations that we could preempt people needing to be able to access in as near real time as we could get them. So we created dashboards looking at incidence rates, testing rates, things like mortality. We also had some of our statistical teams working with the UK modelers to model future waves of the virus. We had their sort of hospital activity trends in there, like, you know, what was our trend looking like on ED attendances and emergency admissions, etc. Another key requirement that we needed to support under the pandemic was around implementing shielding. So we had to identify patients across the system who met our criteria for vulnerable people in our population. And this required us to analyse a whole range of data from different sources to identify that and create a list in the centre of people which we could do a demographic trace against and have letters issued and things like you know, food parcels and other support really that was required. We played a huge role in the data management and reporting from Test, Trace, Protect. You heard Faith talking a little bit earlier around the support that we had from Microsoft in terms of our vaccination and our TTP digital systems, but the information services team did quite a lot in terms of reporting and analysis of the data that was under there. So some of our reflections over the last 12 to 18 months, well, I think echoing what Helen said in her beginning introduction, was that I think COVID taught everybody who didn't already know that data is king, and data is actually really important. And without data, we're just people with opinions. So I think that that's been a huge positive for us in terms of as we move forward into the NDR, which I'm going to talk about in a second. We had a lot of challenges throughout the pandemic. We didn't always get it right. We were dealing with data that we'd never seen before. It was raw, it was coming from operational systems, and we had to make sense of it within really tight time constraints. We had to justify numbers. You know, when you're pulling data at pace from lots of different data sources, inevitably, you know, you're going to be questioned, why has this organization come up with a different figure to you? You need to be really clear on how you've reached that end number. And actually, if you're measuring different things, you need to be clear about that. Technical challenges were significant. So, you know, the way that we flow data around the system is quite old fashioned, really, in terms of within NHS Wales for secondary uses. So it's extracts of data sent in files. You know, there's quite a bit of latency in the data. So trying to implement those really timely and quick data pipelines, you know, directly from the back of our lab systems was definitely a huge learning exercise, and we didn't want to create technical debt for ourselves, but we had to also make things work quickly, and you get a bit of a trade-off then between some of your formalities of your documentation, which you have to go back and do, obviously, once the data is flowing. Having said that, I think Helen's touched on some of the positives really that came out. One is about people actually, it raised the profile of data and why it's so important. We should have had that data at the onset of the pandemic to be able to, you know, to support Wales in getting through that. We shouldn't have had to have been fishing around the system for that data and trying to work it out. We had a really shared vision, so actually we were all on the same side. Everybody was working together, and that helped us to get things done at pace and accelerate some of the things that, you know, we've been working towards for a long time around, you know, our moves to the cloud and some of the more modern tooling and technologies that we had to implement. So going forward, so I'll talk to you, this leads me quite nicely onto the National Data Resource. So the National Data Resource Programme was formally established in 2019. It's a strategic imperative for health and care in Wales, and it underpins all of the delivery of the commitments that we've made in a Healthier Wales and our digital strategies. It's a whole system approach to becoming data driven. It's about using big data technologies. It's about being able to have data shared, you know, through industry standards and made available as and when we need it in a safe and secure way. We talk a lot about big data, and actually within NHS Wales, we're really quite far off that. Our ambition is quite far away from the reality of where we are today. So we look at a lot of activity data, but you know, there's so much more data being produced every single day across the health and care system, from devices to Fitbits to your phone apps, from genomics to imaging. And actually the NDR is about being able to create that big scale data platform to actually exploit all of the data in the system. And that's really important, because where we want to get to is not just being able to understand what happened or why it happened, but actually what will happen in the future and how can we make that happen, and actually how can we move towards a more proactive health and care approach. Listed some of the key partners just on the bottom slide there. So it's an all Wales collaborative across Welsh Government, NHS Wales and social care. And we've got some commercial and academic partnerships as well. I'm conscious of time. I won't read you through this slide, but I think our response to COVID-19 pandemic has powerfully illustrated the benefits of data, our understanding of the disease and our ability to support people, and our cooperation across the systems have all relied on the responsible and effective use and sharing of data. So I don't necessarily think I need to spell that out to people at this point. So over the last 2 years, so the NDR program is a 10-year program. We are 2 years into that program, going into year 3. We have had resources deployed to support the COVID pandemic response that I talked you through in my earlier slides. But actually, whilst doing that, we've been able to learn and develop our capabilities to actually reach our sort of conceptual target architecture, which is built on our understanding of our strategic aims. Some of the things that you've seen here will, I think Faith talked about FHIR as our fast healthcare interoperability resources. That's our standard for exchanging health and care information. But I won't talk you too much into this because I am the program director, not the architect, but very happy to pick up any questions offline on any of this. So that really was about accessing data and actually the architecture you need to be able to store and use data. But also as part of the NDR program, we've set up an advanced analytics work stream, which is focusing on all of the different use cases and the proposals that we want to do with that data, as well as considering the analytical tools and capabilities that we aspire to have across the health and care system in Wales. So, you know, I mentioned it before, and I think it's important to say it again, you know, where we are to where we want to be is really ambitious. So we have to really, you know, invest in our workforce and our skills and our capabilities to be able to get there going forward. So over the next few months, we'll be taking a bit of a strategic reset of the programme. And I really liked what Faith described in her slide deck, really, which is about actually the post-COVID context. The NDR programme was established before the pandemic, and actually the world has moved on, hasn't it, quite significantly. So we are taking a short bit of time to reflect on our priorities now as we support the recovery of the health and care system. And revisiting our priorities and setting that out whilst building our sort of data platforms that we need to get in place moving forward. And that's it from me. Thank you, Helen.
Oh, that's great. Thank you. Thank you to all on the panel. I think now we've got a short video before we move into the Q&A section.
So about 4 weeks ago, I was redeployed in the stroke rehabilitation ward. And I think kind of quite quickly what struck me was the patients that were there had been through quite life-changing events. It became quite apparent that the impact of them having no visitors, things like no magazines and no papers on the ward because of the infection control. The days were really long for the patients and they were looking for a lot more reassurance about what was happening. They were really confused about why relatives weren't coming to see them. Had they been left there? Were they coming back for them? It was getting to the point where it started affecting me because I could kind of see the impact and I felt a little bit helpless. I was having a chat with one of the healthcare support workers on the ward one day, just talking about our frustrations of that situation and the impact on the patients. And she said, oh, I've had an iPad donated. In the office, it just needs setting up. So I went into the MDT room with one of the doctors and we quite quickly got the iPad set up. And within half an hour, we were on our first virtual call with one of the patients who hadn't seen his family for about 6 weeks. His son was really unwell and was going for his own treatment at home. So he had a lot of fear about whether he was going to make it, whether his son was going to make it, whether they were going to see each other again. And instantly, the connection when we came on the video between the patient and his son was just amazing. There was kind of tears in their eyes. It really struck me. And it was just an incredibly powerful thing that just reminded me of that basic human instinct that we need to connect. We're social people. And the love just kind of poured through from both ends, you know. It was a really lovely moment. And it was such a simple thing to do, really, to just go and get the iPad and make it happen. And from there, we just decided that there's no reason we couldn't be carrying on doing that. So we kind of set up a virtual visiting book then, had to ring some relatives, get some details of what platform they were using. And the difference in some of those people has been incredible. Their mood has changed. They're more motivated to return home. They can't wait to see their families. And I think also on the other side of it, the relatives have been anxious about knowing about what's going on with their loved ones, and they've had that daily update. I think it's allayed a lot of their anxieties as well. So yeah, really kind of important project. And I think we've learned so much as a therapy team and how we can continue past COVID to make this possible, because there's always going to be people in hospital who can't see their relatives. And yeah, the only way is up, really.
Oh, I just want to thank colleagues in Swansea Bay University Health Board for the videos there. So I'll open it up now. Then we've got a few questions that have been posted. So Chris, one for, if you can kick us off, you mentioned policy to patient. How do we ensure that patients' views are considered when developing new platforms and guidelines? I'll come to you first. You're on mute, Chris.
Thank you. Well, patient views are integral. I mean, we start at the position where patients have the answers. And if I take, for example, the COPD and asthma self-management apps, the starting point was going out to third-party event, which is held by the British Lung Foundation very kindly. I think there were about 70 patients, and there was an event with live anonymous surveys, feedback, all sorts of things around creating this innovation. There's been more and more iterations of that right the way through, and even with the app having been developed, we have this constant review of sample, review and adapt. And we're continually doing that, and it's patient driven. The medicine is the medicine. The policy to patient in that is there. That's driven by science. But in terms of delivery, and from a patient's perspective, they're absolutely fundamental and key to the heart of what we do. Absolutely.
And Faith, really coming to you from a Microsoft perspective, then really, or even a wider commercial perspective, getting that voice of the users and then of the kind of the wider public. How do you achieve that?
Well, I think Chris put it brilliantly when he said, you know, the patients have the answer. When we talk about any solutions that are being put into place to service the patient, service the citizen, service the user, you know, we're talking about being patient-centric in our approach. I think, you know, for us, it's about, I guess almost working backwards, you know. So what's the end result that you want for the patient, and then using that view in terms of how you effectively design the service, design the application or the piece of software. So, you know, actually we build platforms, and our partners tend to build those kind of very specific applications on top of those platforms. But in anything that we're putting in, it's always, and I guess to a degree what the clinicians also require to be able to deliver that patient service. So I think there's kind of a dual aspect to that in terms of the way that we think about it.
Great, thank you. Another one for you before we let you escape on this one. So one from Carol Shillabia. So you flagged AI as a way of helping tackling the backlog of planned care. What stage is the development at? And is it being used in practice? You know, what are the results and the impact? Something that's obviously very like that was one that I scrolled down when I saw that, really, in terms of the work that you're doing with NHS England. So can you share a bit more on that?
Yeah, so look, I mean, I think that's kind of a fairly new thing that we're putting in place with some specific customers. So look, I'm really happy to get more information and to share a bit more detail around that with you. Again, you know, because we can talk about it insofar as our customers have said, yeah, you can start saying we're doing it. But in terms of the results, I'll get that information from you and get that kind of thumbs up that we can start sharing that. But it's something we'd love to explore with any of the organisations within NHS Wales.
Thank you. And then a question for me, actually. I had one question there, Rebecca, really. a bit around open standards and interoperable approach. I mean, and it's probably one to bring you all in terms of responding, but there was a very complicated diagram you put up there in terms of the architecture. So how close are we to having that open standards, open interoperable architecture in NHS Wales? To Rebecca, and then perhaps a reflection from how engaged our commercial partners will be in their ability to kind of work in that environment. I think if I could ask you that after Rebecca's come on.
Thanks, Helen. I was trying to multitask there and read the question that you were posing to me. Yeah, I think one of the key priorities within the NDR program at the moment is opening up of the existing architecture, and clearly, you know, to be clear about that, you know, that's not a free for all. You know, opening up the architecture doesn't mean open access to data. That has to be managed in a very safe and secure way. So some of our focus at the moment is around the procurement of our API management tools. They're almost like the security guards for the data, really, in terms of who can access it for what purpose, and it provides us with that really strong monitoring and audit tools really around those access to the APIs. So I would say that we aren't far off, actually. I think we have described the architectural roadmap to opening up of the repositories. And as I said, until that can happen, really, we need to put all of the safeguards in place to make sure that we're doing that under the right governance.
Thank you, Becca. Faith, if I can bring you in terms of the kind of commercial sector's ability to work in that way. It's a shift, isn't it, that we're seeing in terms of that open architecture models. What do you think?
Look, yeah, absolutely. I mean, I guess I can only really speak from sort of the Microsoft point of view on it, but you know, as I talked about in terms of the standards, you know, as I said, we build platforms. So when we're talking about the data platform, that's Azure from Microsoft. And it's completely open. It supports all the different developer languages, and it is designed to kind of deliver those open source services. And I think we see that as massively important because we are, as we spoke about, extremely reliant on our partners to be able to build out some of those kind of specific use case applications. And that requires open access to the services, kind of, you know, that opening up of the data in the right kind of way. So, I mean, I think we'll only see increasing that in the market. You know, the days of things being proprietary are gone. I think everybody realizes that that is not the way forward. You know, when you get that kind of system, that's the kind of system that I guess we've almost kind of grown up with, where you do have to regather the data, kind of put the data in a whole new format, get new linkages and connections, and that isn't what the world is about in technology these days. So you know, from Microsoft's point of view, that's absolutely how we build our platforms. But I wouldn't suspect you to get a vastly different answer from a lot of our kind of partners and competitors in the technology market now.
Which a few years ago, perhaps only a few years ago, would have been a different response.
Very different, yeah.
Yeah, I think that we're seeing that kind of sea change, aren't we? And I guess linked to that then is Rob Salter's question there. How far are we from a position that all technology purchases will be mandated data storage via a Welsh clinical data resource? I think that stands for to meet a patient expectation that we should be doing it. I think that is about kind of the expectation that we collect and store data in a structured, safe way, really, isn't it? So Becca, can I ask you about that one? What we're doing already and what you think more we could be doing?
Yeah, I would actually reflect on the work of the Welsh Technical Standards Board there. So the Welsh Technical Standards Board is our part of our current governance process in NHS Wales, and actually it's already made some clear statements around the use of FHIR for exchange of data and information. So you know, part of the work that's going on in that space is actually how do we embed the standards requirements for NHS Wales as part of our big procurements, so that actually we are clear for all of our suppliers how we want to interact with the back end of the system, and actually how we want to be able to move data around the system. So there is a lot of that going on in the NDR space, particularly around standards and interoperability and setting out our expectations. But there's also some work that has been published already by the Welsh Technical Standards Board and the principles in there. So happy to share that with you, Rob, and pick up a conversation offline as well.
Thank you. And then a question from Olivia Baker. The safety of patient data is something that has been discussed in the media more and more in recent months. Yes, we've all seen that. What are the NHS and its partners doing to keep patients' data safe, and how can we reassure them? Chris, can I come to you as a partner with the NHS on this? You clearly will have considered this quite a lot in the development of the work that you've been taking forward.
Yeah, sure. I mean, I think again this starts with I would say being what we call being demand orientated. What would one expect? So if we take something like patient data, what would a patient expect? And so we're very clear in terms of with our the data that we hold and how we hold it, is that we make it very clear to patients that their data is not used for any commercial purposes. It's not sold or given to any third parties. It is used for research. It goes back into the NHS. We're very transparent about that. And actually, patients are generally very giving, but it's about trust. And it's the same thing working with the NHS as a partner, that it's that same dynamic. I mean, of course, underpinning that, there has to be certain standards, and one needs to conform to those. And there are lots of good standards out there, whether it be ISO. So we have an ISO 27001 for data management, the Cyber Essentials Plus. So all of those you would expect, and working with organizations as you know, with faith of Microsoft or other organizations where there are high quality systems which are also governed by those standards, and that's expected, and we conform to those as anybody would expect. But I think that there's also an element of ethos and trust as well, which has to be very transparent, particularly with patient data, and also healthcare professional data for healthcare professionals who use the systems as well, because that's also important too.
Thank you, Chris. And I guess from an NHS perspective, there is the actually it's a paramount, pivotal kind of importance really in terms of the trust. As you say, we need to be really open and transparent of what data there is and how it's being used and how it's being safeguarded. So you're right, you mentioned a few things there. It's kind of multifaceted in terms of kind of the legal basis that we have, the policy that we will have in NHS Wales, set by Welsh Government in terms of the use of the data. But it's really being able to describe all of the safeguards that we would have in place, isn't it, really, so that we can have that conversation with the public, and they can be assured and reassured that that there are all of the safeguards in place to keep patient data safe, but also that it is being used to best effect for all, really, because I think that we've got to take this conversation out there to the public in terms of, actually, there's probably never been a better time, you'd think, is that, you know, in terms of all that we've talked about today, actually, and we've reflected on in terms of the importance of data and how it's helped us to respond to the pandemic and to respond in the way that we have. So it's probably, you know, you wouldn't get a better example of why using data for the greater good is so important, but we do actually have to have that kind of clear, transparent, open conversation, I think, about what, you know, why that's so important, but also all of the safeguards that are in place to actually protect patient data from you know, just to make sure that we are using it safely and ethically, really. So yeah, lots of work going on in that, and actually there is an information governance subgroup of the National Data Resource Programme that is it's got a multi stakeholder representation on it, but also some work in Welsh Government in terms of planning that kind of wider patient involvement and how we take that forward. So I think watch that space, Olivia, actually over the coming months, actually for more on that. So I wonder, I can't see any other questions in the chat bar. I wonder if there are any kind of final reflections from our panel before we take the session to a close. So Faith, if I come to you first.
Yeah, I think a reflection for me, I mean, it's been great to listen to Chris and Rebecca as well in terms of kind of what the work specifically that NHS Wales is doing around data. I think, it's really, thinking about how data can be used perhaps not differently. I know Rebecca said the project was underway before COVID, but perhaps in a kind of, a more open view that actually data has a serious role to play in how we deliver healthcare in the future. All of the kind of patient safeguarding and information safeguarding, it being taken into account. But I think it's really exciting to hear what NHS Wales is doing and thinking about kind of as we start to deliver healthcare in a post-pandemic world. So that's just been great to be part of the discussion.
Thank you, Faith. Chris, if I come to you for any final reflections.
Yeah, well, it's a very exciting time where there's a lot of possibilities and responsibilities. I think where we are pioneers in this new era, and that's just by the fortune of and luck of time. But I think it's something which I think is a real privilege, actually. But it is a responsibility, and if we get it right, and we lay the foundations strongly and positively, then there'll be great legacy for putting in an infrastructure that will create immense value for many decades to come and beyond.
Thank you. And Rebecca.
Yeah, I would agree actually with my colleagues. I think we're at a really exciting time now where actually we can maintain the momentum of how important digital and data is to transforming the services that we deliver and the care that we provide for our citizens in Wales. And I guess just one last point really on the IG side is just to give some reassurance that the information governance considerations and the data privacy engineering considerations are absolutely at the forefront of everything that we are doing in the NDR space. And you mentioned there interestingly about how can we reassure patients and reassure them. We are patients too, the people who are building these data platforms. It's really important to us as well that data is really safe and being used in the right way. So just a bit of an add-on there as well as a reflection, Helen. Thank you.
Thank you, Rebecca. And I guess from my perspective, actually, I think we've used the word exciting actually a few times today. It's been quite a reflective kind of session, hasn't it? And I think it's been quite helpful. Actually, we don't take enough time often to reflect. There's not been that much time in the last 18 months. I think it's been, we've had some great examples actually of how data and digital innovation has actually really supported not just the pandemic response, but actually supported the way that we can and do deliver services. I think there's a lot more to come. There's a lot more innovation in this space, powered by digital and data. But actually, I think that the main take from there, and actually perhaps reflecting on the last bit of the conversation about kind of, how do we reassure people that we're doing this properly? Because this is about people, actually. This is all about people. It's about, it's about patients. It's about the population of Wales and how actually we will support the health and well-being. So not just in the delivery of health and care services, but actually more widely in that patient empowerment and allow people to be fully participated in their health and care. So there's a lot more innovation to come in this space. And I think a lot more partnership working. I think one of the reflections for me is there were strong partnerships that actually got us to some of those innovations and got us to be able to sustain and connect in the way that we did. And we listened to each other, you know, across boundaries, across agencies, across sectors. And I think more of that we've got to do really to really kind of harness the power and the opportunity that we've got. So I think for me, just to say thank you to the panel for a really enriched discussion, and thank you to colleagues who've dived in to listen to us and for your questions. And hopefully you've had some insight into the huge opportunities that data and digital are actually going to bring to the health and care sector in Wales. So hope you enjoy the rest of the week with the rest of the lecture series, and thank you so much.